Welcome, everyone. I'm Phaedra Kress, your moderator of ASJ GEMS. We have double trouble here today. We have both Dr. Andre Auersvald and his brother, Dr. Luis Auersvald. They are the creators of the hemostatic, or ANET, and they're here to present the hemostatic ANET for facelifts, technique, and clinical applications. Dr. Andre Auersvald is a board-certified Brazilian plastic surgeon with more than 3 decades of experience in aesthetic and reconstructive surgery, specializing in facial and cervical rejuvenation. He's internationally recognized for his experience in deep plane facelift techniques and innovative strategies to improve surgical outcomes, including the creation of the hemostatic net. He's lectured extensively at national and international meetings and serves as the founding director of the Full Face and Neck Surgical Anatomy course. He's a member of the Brazilian Society of Plastic Surgery and an author and reviewer for the Aesthetic Surgery Journal. And Dr. Luis Augusto Auersvald is a plastic, reconstructive, and aesthetic surgeon based in Curitiba, Brazil, specializing in facial surgery. He holds the dual board certifications in general and plastic surgery, and he's trained and worked internationally, including research and clinical experience in the United States. Dr. Luis Auersvald is a member of the Brazilian Society of Plastic Surgery and ISAPS, and co-director of the Full Face and Neck Surgical Anatomy course. He's published influential work on facial rejuvenation and the hemostatic neck technique, and he lectures at plastic surgery courses and congresses around the world. Welcome, doctors.
Thank you.
We are very happy to have you with us.
I'm Andre Auersvald. Yeah, and thank you so much for the Aesthetic Society having us here to share our concept of the hemostatic net. We've been doing this for many, many years, over 20 years, so it's going to be very nice to have this conversation. And Luis will start introducing the technique and the concepts of the technique. And then I will go to the practical part, showing how we apply the techniques in some cases that we did, especially for the ASJ journal, okay?
Thank you. So we're going to start with my presentation first. It is a pre-recorded video with all the details of the technique. We have no conflict of interest. So here we go. Thank you.
Just a second, tem que compartilhar com o som. I have to share with some. Just a second. I have to share with sound. Just a second, please.
Take your time.
Okay, no, it's okay.
While we're getting started and they're preparing the video, if you want to let us know where you're joining from today, city, state, country, feel free to put that in the chat box, along with any questions that you have, which we will be addressing in what I'm sure will be a hearty Q&A session after the lecture.
Thank you very much. Andrea and I co-authored the original description of the hemostatic net 15 years ago. The most common complication associated with retidectomy is hematoma. The prevention of this complication is absolute hemostasis, and since Baker and Gordon wrote these statements in their pioneering article in 1967, many authors have studied this issue, debating its pathophysiology and searching for an effective way to prevent its occurrence. About 30 years ago, we began to try to improve our results in face and neck lifts. We sat in the audience of several American meetings where we saw our American colleagues showing their marvelous results, and we'd go, you know, we want to have these results. But in order to have those results, we knew that we'd have to open the neck more frequently. So we began to open almost all necks, aiming at solving our problems of insufficient results, just to learn that the more you open, the greater the detached area, and consequently, the greater the risk of hematomas. Norman Waterhouse and his colleagues have demonstrated this to us in this elegant and to date possibly the most complete multivariate analysis on the issue. Opening the neck is the single riskiest factor for hematoma. So these situations began to occur more and more frequently, often in a very dramatic way. As you can see here, this patient rushed to the hospital in the middle of the night because she had this expanding hematoma, a very dramatic situation. Many times, we felt like performing medicine or surgery in medieval times. It was really dramatic. This patient, for example, developed an expanding hematoma just after he ate, so we had to solve everything with local anesthetics and draining the hematoma with high blood pressure because of the pain and the agitation of the patient. The problem is that hematomas can lead to necrosis and many times to prolonged edema, making it troublesome in the relationship between surgeon and patient. But we were not resigned to this situation, and Andrea and I embarked in a sort of a mission to find the holy grail of total hemostatic control. Of course, we stand on the shoulders of giants, and the inspirational ideas of Drs. Baroudi and Pontis with their internal and external quilting sutures paved the way for us. Taking patients back to the OR is stressful for patients and the surgical staff, so we began to treat hematomas by aspirating and placing external quilting sutures. This is one of the very first cases of the hemostatic net, dating back 20 years. Through time, we observed that the flaps were viable and there were no healing issues on the skin. This is another case where you can see the hematoma and the hemostatic net applied. And here the patient, after a few months, with the case resolved. Now, we expanded the use of the net for situations such as this one. 7 days after surgery, this patient decided to clean the floor of her house. She squatted several times, and the result was this very large expanding hematoma. She rushed to our office, and we had no time to take her to the OR. The problem was solved in the office with local anesthesia and the application of the hemostatic net, as you can see. Now, the net is applied in columns, as it always is, and in this case, we do progressive columns, just pushing the blood out of the territory where it was collected, as you can see. At the end, the problem was resolved. In 4 days, this is the amount of blood that was collected in this situation. And 4 days after the hematoma was drained, the patient returned for removal of the hemostatic net. We just cut the loops and remove one by one. And in this case, she had a small amount of residual blood that was drained at the bedside. We placed another hemostatic net, and the case was resolved. Okay, so one could argue that we have not tried everything to control possible bleeding. But yes, we have tried many things. It's the tireless hemostasis, drains, fibrin glue, PRP, compressive dressings, strict bed rest, strict blood pressure control, antiemetic measures. But despite all our efforts, sometimes we still had some hematomas. For example, in extreme agitation after surgery, this is a situation that you don't really have control over. So a patient like this, if she doesn't have the protection of the hemostatic net or another method to really prevent bleeding, she will eventually have a hematoma. Fortunately, she had the hemostatic net and nothing happened to her. Nausea and vomiting is another issue. You just really cannot control. Some patients tend to have this sensibility to vomit after surgery. They do vomit, sometimes for many hours. Other patients cough, and you cannot have exact control that this patient was not coughing before surgery. After surgery, for some reason, she started coughing, and this can lead to hematomas. Another situation, is a laryngeal spasm as the patient was waking up from anesthesia. Fortunately, he had the hemostatic net that protected him, and in this case, the patient did not have a hematoma, something that probably would have happened if we did not have the hemostatic net. Now, the mechanical principle behind the net is the same as that in the theory of plates and shells from civil engineering, which states that certain surfaces bend and deform with greater difficulty if a mesh is incorporated within them. So a flat surface such as this one will deform with fluid, but a flat surface with a mesh like the skin with the hemostatic net will not. So there are some principles for the use of the hemostatic net. Transfixing suture should embrace this mass platysma below. All areas should be covered with parallel columns, and loops should be about 1 centimeter apart and not overlap. So after 5 years safely and successfully using the net to treat hematomas, we decided to use it as a method to prevent hematomas. These are our 2 original publications, one in Portuguese and the other one in English. In these publications, we've demonstrated absolute hemostatic control while the net is in place. Now, this is how we do. We mark all the detached areas, as you can see. So after the flaps were tractioned, after you did all your neck and middle third work, and then we apply the columns with nylon 5/0 with 30 to 40 millimeter needles. These needles can encompass easily the mass platysma below. So we start with 2 columns in the upper part, and then 2 columns inferiorly, and with that the skin is distributed. We usually merge the columns here right along the margin of the mandible, as you can see over there. So this is the sequence of stitches that were placed in this patient. And then, as you can see, there's a very adequate redraping of the skin. We also do place the hemostatic net on the deep plane territory, on the submass territory. And why? Because you may have hematoma as in this territory as well. This patient had a deep plane, and after 36 hours, she developed hypertension and a hematoma that was drained. As you can see, this is the deep plane territory. We are removing the blood clots from there and washing, rinsing, and placing the hemostatic net just to close the territory where the bleeding was. So at the end, this patient had a very good outcome. She did not have healing issues. You may think that perhaps she could have healing issues in the area where we placed the net, but here she is a few months after surgery with a very nice result. In our initial reports, we saw no difference in ischemia or necrosis, and in fact, some studies proved the preservation of blood circulation in these patients. Now, Milan Kashar, Gerald Little, Gerald Daniel studied the effect of the net on blood circulation with fluorescence angiography and demonstrated that it does not impair blood circulation. This is also what we found in our patients, as you can see in fluorescence angiography. Now, we know that indirect linking vessels are important for blood to reach neighboring perforasomes. Guillaume Emery and Ali Moujalal from Lyon have used the cadaver model to demonstrate that these indirect linking vessels between perforasomes are intact with the net. This group from Turkey studied the effect of the application of the hemostatic net in flaps on the back of rats. They applied the net and left it for 60 hours or 7 days. They also had a control group. They analyzed fluorescence angiography and blood vessel count and came to the conclusion that there is no difference in perfusion between the net and the control group. In the histological analysis, they observed that the group without the net had a lower vessel count, when compared to the control groups. This indicates that the fixation and immobilization provided by the net promote the formation of vessels. The net may have a beneficial effect on perfusion by distributing tension more evenly across the flap. It also may have a beneficial effect on flap nutrition by preventing fluid below the flap, favoring inosculation. Now, one of the questions that we are frequently asked is the potential injury to the facial nerve by placing the net. We have not observed differences in facial nerve injuries. In fact, the net is applied in a more superficial level than sutures to dismas platysma, for instance, in applicature. Fausto Viterbo and Matheus Fernandes from Brazil have shown in a rat model that procedures involving the infusion of local anesthetics or saline solutions, or even suture with needles, are safe with regard to peripheral nerve function loss. The net has been used by several surgeons around the world. This clinical report by Norman Waterhouse from the UK has shown a significant reduction in hematoma formation. This meta-analysis has demonstrated in 7 studies with close to 2,000 patients that the net is a safe and effective procedure in facelifts. Now you follow the principles and you innovate. And that's what Gustavo Abrile from Argentina did in cranioplasties with the help of his resident, Dr. Juan Martinez. This is their typical case of cranioplasty, as you can see. And this is the typical complication with cerebral spine fluid and blood accumulation together. This increases the risk of infection and rejection of the implant. So they began to apply the hemostatic net in their patients and solved the fluid collection problem, as we can see in this patient. We can observe the stability of the flap. But you could say, okay, but how does this work if you're not encompassing the bone, you're not encompassing the implant with the needle? It's just that here the net works as the mesh between 2 pillars, blocking the expansion of the skin. This is what we can see in this other patient with a much larger defect, and the placement of the customized implant, the hemostatic net applied, the immediate result, and 6 months after surgery. The same mechanical principle can be applied in donor sites, as did Ronaldo Regueso in latissimus dorsi flap patients. This is another case from Ronaldo, now in liposuction in the sacral area. And here in gynecomastia, this is a topic with an interesting publication by Norman Waterhouse, Gianluca, and Marco Pacifico from the UK. João Medeiros from Rio has applied the net in both cosmetic and reconstructive surgery. In this case, he converted the implant plane from subglandular to submuscular, and he closed the dead space with the net. Here the patient right after surgery, and here a long-term result. In this patient with a large breast tumor, the residual area needed gliding and adhesion, which was achieved with the net. So here we can see João Medeiros, who did this case and sent to us, applying the net, and this is intraoperatively how the patient looked, and 7 days after surgery with no fluid or no hematoma collections. Now let's go back to the cosmetic surgery. The hemostatic net aimed initially at hemostatic control, but to our surprise, it led to the development of a new area in plastic surgery, the gliding surgery, in which the skin is repositioned, redistributed, and glided to achieve better outcomes, arguably allowing for extended dissections with reduced scars. So treating the lower neck, as in this patient of ours, was always a challenge. We began by amplifying our cervical dissections to glide this lower skin superiorly. The net helped in these procedures, and it would be really difficult to achieve this type of result if it weren't for the net. Then came Fausto Viterbo with gliding brow lift with no scars. and Jerry O'Daniel with the gliding lip lift, and Ozan Saucer with the glide lift. The list does not stop there. Francisco Bravo has applied the concept in blepharoplasty, and Francisco Villegas from Colombia has also introduced the technique in otoplasties. Now, recently, many authors have reflected about the hemostatic net and its role in face plastic surgery. As Dr. Nahai recently wrote in an editorial for this journal, although many surgeons have adopted this tactic to all their patients, others have selectively used it, and some don't see it as necessary. Now, after almost 20 years of the use of the hemostatic net, we see it as a valuable tool for skin redraping. As for the hemostatic control, we continue to concur with Baker and Gordon. Prevention of hematoma is absolute hemostasis, an objective that the net efficiently delivers. However, with over 2,000 patients and no bleeding after surgery with the net, we can no longer say that the most common complication associated with hip reticectomy is hematoma. Well, thank you very much for this opportunity, and now I yield to my brother André, who is going to continue the talk, and he's going to show some very interesting details, technical details, and some very interesting results as well. Thank you.
So I will move forward to my presentation. Fedra, may I?
Yes, please, of course.
Okay. So thank you so much to be here with you today. And thanks for my brother to help me along 25 years. We operate together. So we developed many of the techniques that we use in face and neck lift. We developed together. So I will start with this patient. This morning. We were talking to you, Fedra, that before we come in here, now is 2:30 p.m. in Brazil. In this morning, we did a facelift. Okay, this is the case.
I'm sorry, Dr. Auersvald, we're not seeing the share screen. We're only seeing
no.
you.
Oh, sorry.
That's okay. Or at least I'm not. I'm not sure if anyone else is. I'm only seeing both of you.
Okay. I'll share it with you.
Here we go. That looks.
Here you go.
Now it's coming up, I see.
Okay, so
yes. And then presenter mode.
I'll start over again. Okay.
Thank you.
Where is it?
There we go. Perfect.
Okay, so as I said, thanks to my brother, he did the first presentation. Now I'm going to do the next one. This is the facelift we did this morning. Was a short neck, male patient, hypertensive, and all those things that we know that can produce a hematoma. So this was done this morning, 7 a.m. We start the surgery, and then in 45 minutes we did the GBL and 4 blephs and the lip lift. And then we move to the deep neck and chin augmentation. We do the chin augmentation with fat. So we get fat from the interplatitular fat flap and we place in the chin. So this is the end of the procedure of the neck. All right, removing glands, doing digastric, subplatysmal work, and lower neck platysmoplasty. So, and then we move it to the buccal fat pad, which is a quick procedure for us at least. We just open a small cut in the mucosa. We pull the buccal fat pad and we cut the excess of the buccal fat pad. We prefer not to remove a lot of buccal fat pad. Okay, just a little bit in this case. And then we did the deep plane facelift on the left side. So it took us 35 minutes. And this is the extent of dissection. This is very important to see that we did a wide dissection to the sternal notch. So it's a very wide attachment because we want to improve the lower part of the neck. And then we did the other side, the right side, it took us 30 minutes, and then we did the hemostatic net, and we finished the surgery. This is what we did this morning. And what is the hemostatic net? Hemostatic net essentially is obliteration of that space. So a needle that transfixes the skin encompass the muscle and exits in the skin. With this, you can obliterate the dead space. And how does it work? So let's see what happened if you have a bleeder. So we open just a small amount of skin, and we intentionally transect one vein. Okay, you can see the vein, which could cause hematoma. And now I will apply the hemostatic net on top of this bleeder. Okay, we know that the bleeder is there, but I'm not looking at the bleeder. I'm just closing the dead space. And you see the hemostasis, there's no bleeding anymore. Now I'm going to cut the hemostatic net, start bleeding again. So this is the concept of the hemostatic net, how it can control a bleeding. It's easy to understand if you see it from this perspective, okay? So let's see the technique. This video we made especially for the ASJ.
Bom, esse vídeo foi gravado para o ASJ. Nós
Just a second, I have to lower the volume. Just a second. Video. It is in Portuguese, so you will not understand. Sorry. Okay, but now you're gonna see the video. Well, we recorded this video for ASJ. We start with tumescent infiltration. So we start with markings, and this tumescent infiltration is very important to create a cleavage plane and a safe plane of dissection, a suitable and safety in the detachment of the flap. So let's start with the GBL. GBL, we modify the GBL, resecting a small amount of skin. So it's a combination of, bicorneal and GBL. We resect just 3 centimeters of skin, and then we redrape the skin with the hemostatic net, which has been very successful for us. You can see the elevation of the brow, and then we apply the hemostatic net, which is a continuous running suture. In the forehead, we don't put too much tension in this suture. We prefer to leave it a light tension, and that's the reason we place a small drain. Okay, you can see there, we are checking the suture just to reposition the skin superiorly. So, and now we go to the neck. We do a more aggressive neck in most of our patients. We really like to treat the area that we call low neck, the area below the hyoid, which is it corresponds to 50% of the neck. And in this case, we removed gland, submandibular salivary gland, digastric, subplatysma fat, and did a wide platysma corset. Now we go to the deep plane. Okay, we're gonna see now how wide is our dissection. You can see there, all this area can be accumulate flood and cause hematoma, as Luis showed before. In this case, now we are doing the needle-guided deep plane facelift, which is a technique that we developed to facilitate the deep plane. So we have needles that guide us the reference of the zygomatic major muscle, the upper buccal branch, so we know where we are navigating with these needles. And then we open the pre-mesenteric space with with the trapsat, and now I know that I'm on top of the zygomatic major muscle. That's because I put those needles, and we finish the release of the zygomatic ligament with scissor, okay? And note the extent of undermining, very wide extent undermining. And this is the transposition of the buccal fat pad. We are gonna pull this buccal fat pad, so you see that we have a more extended detachment. So it's important to understand why we are gonna use the hemostatic net on top of this subplatysma detachment. And this is the way that we transpose and secure the buccal fat pad, since it's a very friable tissue. This is the mechanism for controlling the position of the buccal fat pad that we developed, anchoring it to the zygomatic major muscle. And then we dissect the cuff, and then we're going to traction, pull, and then the first suture to define the cervical mental angle, the jaw, the angle of the mandible, and then we pull the mass cuff to the fixed platysma, to the fixed mass. So this is the traction. So essentially, that's what we do for the facelift, and we remove the fat on top of the sternocleidomastoid, and we detach the neck up to the clavicle, almost close to the clavicle. And now we see the extent of dissection, which is really very wide. And then we began to use the hemostatic net, which was created by Dr. Baroudi. Dr. Baroudi created this abdominal quilting suture, which reduced seroma and hematoma to zero. So, and this is what happened with an isolated suture. You see, stabilize the flap, and now I'm going to release that suture, and you see that the flap becomes mobile. The deep cervicoplasty was performed, removing the subplatysmal volumes for the definition of the cervical contour. Now we are marking the subcutaneous areas of detachment. And this area is the deep plane that also has a potential of bleeding. So Luis showed that the way that we close this dead space, we use a 4-centimeter needle, which encompass this area very thick to obliterate the dead space generated by the deep plane. Now you're going to see the timing is 10:25 a.m. and we are going to start the hemostatic net, okay? So practice makes these procedures faster, and using appropriate needles make it more quick. The net is a continuous running suture that encircles the skin and this mass. We use a 4-centimeter needle. There shouldn't be much tension in this suture, of course, not to strangulate. The suture must be very light. And so at the end of the suture, we check the tension with the look here. So the needle transfixing the skin and encompassing the musculature. You can see the endoscopy view of this hemostatic net. You see there? It obliterates all that space. At the end of the column, an important step is checking the suture tensions. This is the way that we use to see if the tension is okay, just using the needle holder, and we pull all the sutures, all the loops, and make sure that there's no much tension and it's not too loose. So it took us 10 to 15 minutes to do this net. And let's see what happened if we transfix jugular vein. This question always come up to the meetings. So you see, if you transfix the jugular vein, there is no problem. And now you're checking again the suture tension. This is very important, okay? This step is really very important. You shouldn't strangulate. This should not be done this way. It should be very light tension, like this one. We can check this with the needle holder. So the obliteration of the cell. Now we're going to inject fluid, okay? With a syringe, we're going to see that in the side, no fluid, without the fluid can accumulate. These are the sutures that we recommend. So this suture is approved by the FDA. You have it available in the United States. It's a 5/0 nylon, 4 centimeter long needle. And notice how the sutures enters the skin, crosses the muscle, and exits the skin again on a continuous running suture. So checking the viability of the flap. In 5 hours after the surgery, we check how the nourishment of the flap. And then this is the first dressing. The next day, before you discharge the patient, we clean all the crustes, and you see that in this case, there is no impairment of muscle movements. And then 72 hours, we remove the hemostatic net, first cutting the knots and then cutting the loops. Okay, this is important. And then if there is this small bleeding, you just can compress this area for a few minutes, and that's okay. And so this is the video that we recorded for your meeting, Feder, and we have other videos I'm going to show in the sequence. This is a male surgery, you see there. Huge submandibular salivary gland. Men usually tend to bleed more, so we leave the suture for 4 or 5 days. You see here. Very nice outcome. And this is another case, 30 days post-op, very thin patient. We recorded this patient for you in this meeting. So this is the patient that we did in the demonstration, and she looks very nice. A few days after surgery. So why dissection? Why we do use the hemostatic net? Because we do wide dissection in most of our patients because we like to have a good improvement of the neck. So we do application below the hyoid. With this, we increase the amount of skin detachment, which increases the possibility of hematoma. With the hemostatic net, we have no hematomas at all. Okay, so in difficult necks like this one, you can say, well, this is a very difficult neck, so we have to be more aggressive to obtain better results. You can see this patient 1.5 years later, and she looks very nice, and she was here yesterday in our office. We recorded for your meeting too. So, and male patients, we just saw this video. Let's move to this one. The low neck is an important part of the neck, as I mentioned. That's the reason we detach more aggressively the lower part of the neck. You can see here, sagging of the platysma and skin. We did this is the lower part of the neck. We did a deep plane and a wide detachment of the neck. It really improves the quality of your result if you plicate down close to the clavicle. I know that you're going to get a wider detachment, but if you have the hemostatic net, you should not be afraid of it. Okay, so this is the detachment of the lower part of the neck. And now we're going to do a placebo application from the chin to the sternal notch. And this is the SPY, where we did an angiofluorescence to check the skin viability. It's okay. And you can see her the next day with a great improvement of her horizontal and vertical neck. Both parts of the neck are rejuvenated. So you can see how beautiful she is after this wide detachment of the neck and with no hematoma and a great skin redraping. So this is her before and after surgery. Okay, she looks gorgeous. Low and short neck. So we did this surgery for the ASJ too. So you're going to see a very heavy and obliterated neck, and how we can control and we can elongate the lower part of the neck. So I'm explaining what I'm going to do here. I'm going to remove fat from the interplatysma area, and in the lower part of the neck, we're going to see this happening now. The wide detachment up to the clavicle. With this, I can reduce the diameter of the neck. So I'm resecting the interplatysma fat from the lower part of the neck. Now I'm going to do application of the platysma, so we don't transect the platysma at all. And you can see here the improvement that she had, of course, in her face and neck. 7 days out, very safe, and a great skin redraping. So it's a very nice result. We can do net in blepharoplasty like this one. This is a patient that we did a wide detachment of the skin of the blepharoplasty. We did an Adamson fixing the orbicularis to the orbit. You can see here. And at the end of the surgery, there was a wide skin detachment of the lower bleph. So what we do, we apply a hemostatic net with a 6-0 needle so we can control any fluid accumulation, blood accumulation in this area. It's very simple to do. We usually keep this for 24 hours only. And then you see the next day, she has no fluid accumulation in that area. Okay. And a nice improvement of this difficult malar mounds. In Asians, you can see here, we did this surgery for ESJ. We have a large Japanese colony here in our city. We do a lot of Japanese short neck, difficult neck, and applying the hemostatic net in Oriental patient. We saw this patient already. And skin distribution, I would say that this is a real challenging patient. How you're going to control this sagging skin in a patient like this one. This is a secondary procedure, and she has a huge amount of skin redundant on her neck. So we did a wide dissection again, and application of the platysma and redraping of the skin with the hemostatic net, bringing the redundant skin superiorly. And this is 30 days, 6 months, 1 year, and at the end of maybe, I think, 2 years with a great improvement. So late result, just to show you, this is a patient that we did a long time ago, and we used the hemostatic net, and we treated the platysma, digastric, and strap muscles, and this is the result 1.5 years later. And she came here for a laser work on her eyes. She's still looking good. She doesn't want to do anything to her neck, just some skin work on her periorbital region and some Botox. So she's still looking good. So I would like to invite you for the Face Master, March St. Louis, February 27 to March 1st, and ISAPS Cancun, October 27 through 31st. Submit your abstract by the end of January, in January 23rd. Thank you, Fedra. Thank you so much.
Thank you so much, both of you. Wonderful presentation. We have questions from the chat box. We're going to launch some polls now, but fantastic, so informative. I'm going to, let's see, I'll launch a poll. So for everyone that's listening in, I'm going to ask you if you could take a moment to read and respond to the poll. Doctors, you don't need to. We'll be reporting on these afterwards. Okay, so a couple things from the chat box. Erica Bartlett is asking what sutures you're using. I believe you said 504 centimeter, but is there anything that you would add to that?
No, it's just that this suture is currently available in the United States, as Andrea just showed, and here in Brazil we developed. We didn't have, because you see the big producers of this suturing materials, they don't have this combination of a big needle for 5/0 sutures. So we developed that here in Brazil, and now you have it in the United States as well.
Okay,
So
that was our second question about what sutures are available. So they are in the US then.
yes,
Yeah.
they just launched that.
Yeah, I think Marina Medical is selling this suture. It's a special suture, the same one that we developed here in Brazil. We developed this suture in
With
Brazil.
Marina Medical.
No, here in Brazil is with another company called Biosuit, but then Marina made a very similar needle and suture, which is great. I tested this needle; it's fantastic.
Yeah.
Fantastic. Okay, excellent. Continue to put your questions into the chat box. Moving on to one from Matthias Tremp. Do you preserve the Roski's patch during your neck lifts?
I beg your pardon?
He's
Preserve.
asking if you preserve the Roski's patch. Am I saying it wrong?
Roski's?
I'm not sure what that is.
Yeah, I'm not familiar either. I'm sorry.
Dr. Tremp, if
Yeah,
you
I
wanted
don't know
to
what
There are
unmute.
some eponyms that sometimes.
Maybe it could be the preservation technique. We don't do the preservation. We do the wide platysma dissection. Maybe this is what this person is asking. We do a wide platysma dissection. The skin is detached from the platysma, and then we can control the sagging of the platysma down to the sternal notch and remove volume from the lower part of the neck. So it's fantastic. It's different from what is the preservation. All right.
Okay. Now,
If I may, if I
please.
may add, it's very important that the flaps, the skin flap, should be thick. With this technique, we need to keep the flaps thick. Otherwise, we may have some ischemia. So we're really careful in dissecting very thick flaps.
Okay.
Yeah, besides dissecting a very thick flap, I think this is very, very important, is injecting tumescent solution. With this, you can get a very thick flap. So both things, tumescent infiltration and thick flap, using Madsen bow scissor. I learned it from Tim Martin. So we have those flat tip scissors. These are not good for saving the vascularity of the flap. We use Madsen bow.
Okay. So let's see here. In asking how familiar are you with the net, 32% are very familiar, 43% somewhat familiar, 18% heard of it but never used it, and 7% not familiar. So that's great. I think that almost 50% are somewhat familiar, and for the 7% who are not, you're learning about it today. In what procedures have you used or considered using the net? Predominantly, as I think we would all expect, facelift and rhytidectomy, 62%, abdominoplasty, 19%, and breast reduction mastopexy, 5%. Is that as you would expect, doctors, or would you have expected to hear a little differently?
No, it is. It is somehow what we see our colleagues here in Brazil doing. We don't do body contouring anymore, but we introduced the idea many years ago as we were doing both facelifts and body contouring, and we started doing that. And it's very useful for breast reconstruction, gynecomastias, and also for liposuction, where you don't want to have that seroma, that seroma that usually happens, especially in the back, in the sacral area. You may use it.
Now, you had mentioned 4 to 5 days the net stays on for men who bleed more. Did you give us the time frame, the exact number of days for a typical female?
3 days.
3 days.
It's
Okay.
usually 3 days. But I know Daniel Labie from France. He's a very experienced surgeon. He used 4 to 5 days. So I mean, we invented technique, but I'm learning from my friend's experience too. Okay, Daniel Levy changed my mind, so I started using for 3 days and males for 4, sometimes 5 days. So before removing the net, we should check the blood pressure. If the blood pressure is high, maybe you can keep the net one more day. Okay, you can get some markings, but those markings are temporary.
I'm sure. Okay,
All right.
very good. Moving back to the chat box here, Kenneth Francis is saying he's had some persistent hyperpigmentation at the net needle insertion point with a Fitzpatrick 4 or 5 patient. Do you have any suggestions? And he's learned to prepare patients for it pre-op.
Oh yes, these situations are usually temporary. You can to use some blanching solution for the skin after that, but they usually tend to go away in a few months. The problem that we have in some patients, which is permanent, is hypochromia. That may happen, and that is more difficult to resolve than hyperchromia. Hyperchromia is usually temporary.
You see, most surgeons do laser. Laser works, some more aggressive laser resurfacing. So those problems that happen after laser therapy, laser treatment, is the same that happens with the hemostatic net. You can get a temporary hyperpigmentation, and you just have to use blanching. You know, the hyperpigmentation happens while there is still the inflammatory process of the healing process.
Yes. Yeah, one thing that is very important is taking care of the dressing right after surgery. You have to clean the hemostatic net while it is on. So you know those small crusts that on the orifice where the thread goes through. You have to clean. You know, chlorhexidine. You just pick up gauze and then wet it in chlorhexidine and just clean the day after and the day after. So you really have a very clean skin. That's very important. So you don't have inflammatory processes, as Andrea has mentioned.
Yeah, I can see that one of the concerns that that there are in this NCAT here is that you may have skin dimpling. Well, skin dimpling can be a problem if you don't distribute the skin properly. I mean, your assistant has to distribute the skin and then you apply the nets. So you have to make sure that there is no skin irregularities.
Yeah, that's why I mentioned that when we do usually 2 columns on the upper part and 2 columns on the lower part, and then you merge them just along the margin of the mandible, just under the mandible here, because in that way you don't have too much skin to one side or the other side. You know, because if I start my hemostatic net, the columns here, and I go up, then I'm gonna have a bunch of skin here. So if I distribute, it's an art. You have to distribute a little bit here, as in any flap that you would just accommodate. Distribute a little bit here, a little bit there, and then at the end, you have a very well redraped skin.
And I would imagine you said one side took 15 minutes, the other side took 30. You're experts, right? So how long can doctors learning and starting this process expect to take? How much extra time in the OR to apply the net? Because you're expert, so I would imagine not everyone can do it in 15 minutes.
Yeah, I don't know. It depends on the skills of every surgeon, and but usually I think that it would be like 30 minutes. That's what we see. Our friends who come and learn with us, then they mention to us, 30, 35 minutes. But as the learning curve goes on, then they reduce the time.
Quicker.
Yeah, one thing that we have reduced the time of cauterization. If you cauterize the tip of your finger, you're going to see that this burn hurts a lot. Can you imagine if we spend maybe half an hour cauterizing this mess? You're going to get a lot of burn and char tissues in the area that you cauterize. With the hemostatic net, we don't need to cauterize. In some cases, I don't cauterize. So with this, the improvement is faster because there is no burning tissue below the skin. So the healing process is quicker.
Right, and I think that's
You know,
definitely a benefit. Here we're seeing in these results, you pointed out the skin dimpling. It was a concern of 45%, but 20% said that they didn't have any concerns. And on the upside, 44% are now saying they're very likely, 39% somewhat likely to use it after what they've learned today, which is great. So I think that's compelling.
yeah, of course, there's a learning curve. It's a continuous running suture. One of the simplest technique that you can learn and that brings a huge benefit. But of course, at the beginning, maybe you can need some, adaptations with the needle holder. I would highly recommend to use this 4 centimeters needle, which makes a lot of difference. We start with 1.9 centimeter needle, 19 millimeter. And sometimes that we wouldn't encompass the muscle and we would have a hematoma in the area that I just transfix the skin and not the skin and the underlying muscle. So this is the process of the learning curve that you have to go through. But I'm sure a lot of surgeons are using this as a routine, and it doesn't take time, this learning curve doesn't
Yeah.
take much.
And the
Okay.
time, I'm sorry, and the time that we spend with the hemostatic net is offset by, well, offsets the time that you would spend cauterizing. So
Exactly.
some people say, oh, but it adds a lot of time. It really doesn't, because
But it
you
really
offset
doesn't.
time that you would be using for cauterization.
That's an excellent point, Doctor. Now, Felipe Geraldo is asking you to elaborate on the potential iatrogenic injuries involving the external jugular vein. Can you say a little more about that?
Yeah, we present in the video transfixing the jugular vein. One of the, maybe I can go over and show it again, but I have to spot the area where I showed the needle is transfixing the external jugular vein. There's no problem at all. Just continues the suture, is going to stop bleeding. The same as I showed at the beginning of our lecture. You saw that big vein that I cut intentionally, and then I cover it with the hemostatic net, stop bleeding. And when you remove 4 days, 3 or 4 days later, it's not going to bleed. Okay.
Yeah, my advice is that if you think that you cut, for example, the jugular vein, don't stop and don't go back. Don't remove the stitch.
Yeah.
You just continue and then give a few seconds and see how it behaves. And if you still have some bleeding, you can put another column of the hemostatic net on top of it just to make sure that it stops. But you will stop. I mean, there's no way. If you do it correctly, transfixing the skin and compassing this mass platysma below, it will stop.
So they can cross over each other because, in the columns that, I
Yeah,
mean, is that not
yeah,
right?
we don't usually. Well, I'm saying that in exceptionally, but
In an
we don't
exceptional,
usually. Yeah, we don't overlap columns.
right,
We don't recommend
typically. But if
overlapping
you
columns.
got the jugular vein bleeding, maybe there's an
Yeah,
exception to
but
do it
if you
again.
have just locally over the jugular vein, you can just pass another column just in that territory, and then it will solve the problem.
Perfect. Okay, Batuan Temis has got two questions for you. What are your experiences with smokers and diabetic patients? And do you suggest if there is a net scarring, what do you suggest if there's scarring or hyperpigmentation, which I think we talked about? So smokers and diabetics.
Diabetes, I didn't change, since I was not using the hemostatic net, and after starting using the hemostatic net, I did the same protocol. I asked for the patient to avoid, smoking.
For how long?
But
2 weeks?
yeah, 2 weeks, 2 or 3 weeks.
Okay.
I'm more concerned about energy devices than from smoking, because energy device can also cause interference in the subdermal plexus. So you may have ischemia, but we did a comparison before and after the hemostatic net, and we have the same percentage of ischemia.
Yeah, in fact, this is the initial series, and today we have less actually, probably because of those
Fine.
studies, those findings corroborate this findings of ours, that we see less and less ischemia and necrosis in our patients.
So speaking of energy devices, is your concern a patient who's had that kind of a treatment pre-op, or is it a post-op concern that you have, or both?
Pre-op,
Pre-op.
pre-op.
And how recently, how close, to this procedure would you like them to avoid any kind of energy-based treatments?
There's an important paper published by Jerry O'Daniel about, interference of energy device. They can coagulate vessels with the fat. The target is the fat under the skin. And with this fat, you can, of course, interfere with the blood supply, but you are not able to assess this preoperatively. If you inject biostimulator or fillers, you can do an ultrasound and check the amount of products that we're injecting preoperatively, but not with the energy devices. So
Oops.
Ave é South America.
Oops, sorry, we've got to
Ave
mute
South
someone
America.
here.
What?
Just bear with
Ave South America.
Are we so Semitic?
Yes, South America.
Okay, sorry about that. Okay.
okay.
Thanks for that comment. Okay, moving on here. Let's see. Okay, I did see a question about the sutures. So we've got the Brazilian sutures, Marina Medical in the States. What are you using or what's available in Europe?
What's available in what?
In Europe? What kind of
Oh, in
sutures?
Europe. In Europe. I
There's
know
a,
they have
there's a
probably-
Turkish
Yeah.
company that produces a hemostatic net too. So, and they have the CE
The CE mark.
authorization.
Okay.
In Turkey, if you want, I can text you the name. I don't recall. Daigon. I don't remember the name.
Okay.
But they can ship it to all over Europe. Here in South America, we have the BioSuit, and in America, with the FDA approval, they have this Marina suture. Okay.
Marina. Okay. We are at time, but we've got a few more questions. Do you have 5 more minutes?
Yes.
Yeah, 5.
Okay,
Mhm.
perfect. We'll try and rapid fire these through. Victoria Imey's asking if you pre-treat the skin to help prevent hyperpigmentation, since it can be done for laser treatments.
Yes, perfect. Yes, sounds good. I mean, if the patient is Fitzpatrick 4 or 5, you can prep the patient.
Okay.
Definitely.
Then we had
I
the Europe
totally agree.
question. Hello from Italy, from Giovanni Brunelli. Ciao, Giovanni. Have you ever had any nerve entrapment issue with such a big needle?
Well, we use very thin needle. Those sutures that we develop for hemostatic net, they are very thin. So even if you transfix a nerve, of course, the same can happen when you do a SMAS plication. If you do a SMAS plication, you can transfix a nerve too. It's not just for the hemostatic net. You can do in whatever technique you use, you can transfix a nerve.
Yeah, in the statistical terms, we haven't seen a difference.
Yeah.
You see, before the net and after the net. And the other thing is that, corroborating with what Andre is saying, is that the hemostatic net is transient. It's like it's going to stay for 3 days. And Fausto Viterbo just showed in this very interesting paper in a rat model, I can tell, but it is a very interesting paper that I just showed, that it does not impair a nerve function for a long-term nerve function. You don't have a long-term function, a nerve impairment with these needles or with these sutures over the nerves.
Okay. We've got 5 out of the 7 continents, by the way. We're only missing Australia and Antarctica, so that's fantastic. Let's see, just 1 or 2 more. Let's see. Abdullah Basse is asking, just want to ask regarding NET's complication like risk of hypertrophic or keloid scars, especially in dark-skinned people. Is that a consideration or something that you've seen? So in keloid or dark-skinned people, any kind of, a hypertrophic or keloid scar in a dark-skinned person?
No, we don't see hypertrophic scar because of the hemostatic net. No.
Okay. And let's see.
Let's not forget that the net is just a small orifice, very small orifice on the skin. It's like when you get an IV. I mean, if like in 3 days you take out the
Sure.
IV, in a few
It's
weeks you
gone.
don't see it anymore. It's the same principle here because it's a concentric healing process that and the loop over the skin is not tight to mark the skin. It's just enough to
Just a little pressure.
make the attachment of the skin to the underlying smash platysma.
Excellent point. Well, I'll close with thanking you and giving you a compliment from Alioro Zartavera, who is going to be using your procedure on Monday in Colombia. So that's fantastic. You've got a new fan here, and we appreciate all of this great information. The recording will be available on the ASJ website and the Aesthetic Academy website. That's our society's website. We hope you'll join us in Boston, and we're definitely coming to your ISAPS meeting. So, doctors, thank you. Enjoy the rest of your day, and happy holidays, everyone.
Thank you,
Thank you.
Fedra. Thank you
Thank
so
you,
much.
Fedra.
Tell that surgeon that asked about the jugular vein. When they go on demand, they can see the jugular vein being transfixed. So it's going to be made very clear for him to understand how to handle
Excellent.
the situation. Okay.
Excellent.
Okay. Thank you so much for
Thanks,
the
everyone. Take care.
ASJ, for you, Fedra, and for everybody involved in the organization. Bye
It's
bye.
an honor. Thank
Thank
you.
you. Bye.
Bye, doctors.